Hello, my name is Stefan Zimmerman. I work with Dr. Fishman here at Hopkins. I'm an associate professor here and do a lot of cardiac imaging. And today we're going to talk about the use of CT in TAVR. So here's an outline of what we're going to review today. First, we're going to talk a little bit about background issues related to TAVR. What is TAVR exactly, and why should you care? Then we're going to talk about how CT plays into TAVR. Review some protocols and analysis, and then finally we'll go over some post-TAVR findings and complications. So first, what is TAVR? Why should you care? So first, a little background about aortic stenosis. So aortic stenosis is a disease that affects 5% of the population, so it's quite common. And in particular, it's very common amongst the elderly. And it turns out that aortic stenosis is actually a quite deadly disease. Once patients are symptomatic, death happens or people die, and over 50% of people die at 2 years. So this is a prognosis that's worse than many of the cancers that we see. The traditional treatment is surgical valve replacement, and that had been sort of the mainstay of treatment for many years. Problem is, though, that this is, again, a disease of the elderly population, and so this is a population with lots of comorbidities, frailty, etc. And so these patients often are very high risk for surgery. And so some patients, a good number of these patients actually cannot have the surgery because they're too high risk. And this is where TAVR comes in. And TAVR stands for transcatheter aortic valve replacement. And it's a great technique for replacing aortic valves in patients who are really too sick for surgery. So TAVR came onto the scene, quite a while ago now. This chart we see here from the literature actually goes back to 2012. And you can see that over the years, TAVR has been growing and growing and growing. And this growth is expected to continue for quite a while. So we as radiologists should anticipate that we're going to start seeing a lot of TAVR if you're not doing it already. And that the number of cases we see is just going to increase over time. And this makes sense. Who in their right mind would want to have open heart surgery if they can avoid it? Certainly the option of having a transcatheter valve where your only wound really is a wound in the groin from the sheath that was placed versus a complete sternotomy. There's obviously a no-brainer kind of situation going on there. So what is the story behind TAVR and why this explosive growth? Well, what's happened with TAVR is basically the valve itself has gone through a series of trials, basically increasing the number of eligible patients over time. So initially, the transcatheter aortic valve was evaluated in patients who were too sick to have any surgery at all. And that's the top of this chart here. Those were considered the extreme risk patients. And so in those patients, the risk of death for surgery was so high that they said they cannot get surgery, they cannot have their valve surgically repaired. And the trial was constructed such that patients would be randomized to either medical therapy or transcatheter aortic valve. And sure enough, the transcatheter aortic valve performed quite well and better than medical therapy. Following those extreme risk trials were high risk trials. So in this case, these are patients who could have surgery, but the surgery itself had quite a high risk of morbidity and mortality. And this would, again, patients were randomized to either high risk surgery or transcatheter aortic valve replacement. And again, the valve performed quite well in that scenario. And now, as we move forward, we're getting into trials that have moved down to groups that are now at intermediate risk, so sort of a medium risk for surgery. And currently, we have ongoing trials now in low-risk populations. So intermediate risk data actually is available and shows that, again, the valve performs well in this group versus when compared to surgery. And so now the next group will be the low-risk group. And so this basically the story that's being told here is this story of expanding indications, and the eligible patient population is growing and growing over time. So right now in the United States, there are two valves available. There are several companies that are working on new valves, and we would expect that over the coming years we're going to see additional valves available from other vendors, but right now we're limited to two. The first is the core valve, which is from Medtronic. And there have been a couple different iterations of this, but the basic design has been the same. And that's this shape that you see here. It kind of has this flared, more superior part that sits inside the ascending aorta. And then there's a prosthetic valve mounted on the more inferior part of the device. You can see the device sits in the region of the aortic annulus. And the arrow on the right-hand image actually is pointing to a chunk of calcium that is part of the native aortic valve that has been pushed aside by this device. And that's how these devices work. They basically sit in the native aortic valve position and push the native aortic valve leaflets out of the way and provide a new valve instead. This is the other type of valve that you're going to see in the United States. This is called the Sapien valve from Edwards. And again, this has gone through a few different iterations. The sheath size actually has gradually decreased over time, and they've added a skirt, which I'll talk about later. But the basic design here, it's a lower profile device, sits at the level of the aortic annulus, and has again a prosthetic valve in the middle. So the important thing here is it's centered on the aortic annulus, and unlike the core valve, the device itself does not go above the level of the coronary ostia. It actually sits just below. Okay, so next we're going to move on to the role of CT in TAVR. So it turns out that TAVR really is critical now for CT is now critical for preoperative planning in TAVR patients. So CT really has two roles in this setting. One is to actually evaluate the aortic valve structure itself to determine the size of the device that's needed to use. And then the other is to look at the potential avenues for vascular access. So to accomplish this, the standard TAVR CT scan includes cardiac gated imaging to look at the aortic valve structure itself. And then this is followed by a CT angiogram of the chest, abdomen, pelvis to look at the vascular supply and to determine what's the best way to best place to place the catheters. So how did CT become so important in TAVR? Well, it turns out that CT, the initial trials, I should back up, the initial trials used echocardiography for valve sizing. And it turned out that using echocardiography for valve sizing resulted in a problem called paravalvular leak. And basically what that means is that the device itself is a little too small for the aortic annulus, and there's a gap between the edges of the device and the aortic annulus. And that gap allows leakage of blood around the device, basically aortic regurgitation. So it's known as paravalvular leak or paravalvular regurgitation. And so echo-based sizing resulted in some degree of paravalvular regurgitation, and more recent data has shown that if you use CT to do device sizing, then you reduce the amount of paravalvular leak. And paravalvular leak ends up being really important for patient outcomes. Those with paravalvular leak do a lot worse than those without, twofold higher risk of mortality in one meta-analysis. So it's certainly very important to avoid this problem, and CT does a better job of avoiding it than echo. Hence, now CT has really become standard of care for pre-TAVR evaluation. So just another slide about paravalvular leak here. This is the concept, sort of a visual drawing of a visual depiction. In this figure, you see the arrow is really blood that's leaking around the device. So pretty simple. I had mentioned some newer iterations of these devices have a skirt, and so they have additional material on the outside of the device, which is basically designed to reduce the amount of paravalvular leak and increase or improve the seal between the valve and the annulus. So why does CT do a better job than echocardiography? Well, here are a couple figures from the literature which kind of demonstrate this. What happens is the way the valve annulus was measured on echocardiography is from this view called a parasternal long axis view, and a single plane measurement was performed, and that single plane diameter was actually extrapolated out to their circumference of a circle based on that diameter. And it turns out that when you look on three-dimensional CT scans, you can map out the actual diameter that was measured by echo, and it turns out that the numbers they got were just a little bit short of reality. So this yellow bar shows you the true diameter, the true long axis diameter of this aortic annulus, whereas the measured diameter by echo is depicted in the white bar there with the little red arrows. So basically there's a systematic underestimation of the actual true annular size with echocardiography, which again leads to the undersizing, which leads to the paravalvular regurgitation. What are some other things that we do with CT when we do TAVR assessment? So not only do we do measurements and try and find the ideal vascular access, we also try to identify high-risk features that may preclude surgical valve replacement. The concept here is that sometimes when the patients come into the clinic, the cardiologists don't necessarily know which way they're going to go. Are they going to go to surgical valve replacement, or are they going to go to transcatheter aortic valve? And we can see some features on CT that may tip the balance in one direction or the other. In particular, we can see CT features which basically tip the balance away from surgery. One of those would be extensive calcification of the aorta, or porcelain aorta, which is sometimes called. This is really just the whole aorta is calcified, and what happens is to do cardiopulmonary bypass, the surgeon needs to clamp the aorta itself and also make some holes in the aorta for various catheters and things like that. If you have a lot of calcification, that becomes very difficult and dangerous, so that pushes one away from surgery. The other feature would be cabbage vessels in the substernal position. So these would be people who've had prior coronary artery bypass graft placement, and their vessels for the actual graft are sitting just below the sternum. And so when you go do a redo sternotomy to replace the valve, those are at risk for being injured. And we already talked about how we use the the CT angiogram to assess the ideal location for placement of or for obtaining vascular access. Generally, the cardiologists and surgeons who are performing the TAVR procedure, they want to use the iliofemoral access route. Far and away, that's the most popular. But in a pinch, if there's a lot of stenosis or there's trouble with the iliac vessels, then they can go to subclavian access. And then as another sort of last ditch resort, they can either do direct aortic, which they actually go between the ribs and puncture the ascending aorta, or transapical, which is really the last choice, which means they go also between the ribs and actually go directly through the apex of the heart. Not surprisingly, patients who have had transapical, which was much more common in the early phases of the TAVR evaluation, those patients who undergo transapical or have transapical access do worse in general than those who do not. Basically you're creating a hole in the heart which has to be sutured up, and there's some negative effects from that downstream. Okay, so next we're going to talk about CT protocols and analysis. So how do you do it when you're at the scanner? These are the typical components of a TAVR CT examination. We talked about the cardiac gated imaging to really look at the aortic valve structure and the CT angiogram of the chest, abdomen, pelvis. The calcium scoring is an optional piece of the exam. Some places do this routinely. I have some colleagues where they always get calcium score because they want to look at the degree of calcification of the aortic valve. In some cases, they may be on the fence as to whether or not they think this patient's valve disease is severe enough to warrant replacement. And if they see a lot of calcium on the valve, then that might push them to actually go ahead with the procedure. There is some data looking at the amount of calcium and the risk of regurgitation, basically showing that the more calcium you have, the more likely you are to have regurgitation. So some places like to get the calcium scoring ahead of time. We do not actually at Hopkins, but that's really up to your own personal preference. The other two components certainly are critical. What are the concepts? So when we put together the TAVR protocol, what do we want? Ideally, you want to image fast at a high resolution. You want to obtain multiple cardiac phases, and you want to optimize your images for post-processing. So this is a typical protocol for a Y detector scanner, 128 slice or greater. We're gonna use a big IV, and we want to inject quickly, 5 to 7 cc's a second. We usually use a fair amount of contrast because we have to do both a cardiac imaging and then also follow with a CT angiogram. So we generally give 120 cc's. If you do have renal insufficiency, you can bring that down a little bit. A saline flush is critical, and I'll show you why. Usually we use a bolus tracker for triggering and then perform the cardiac scan immediately followed by the CTA of the chest, abdomen, pelvis. 64 slice scanners, that's where you get into a little bit more of a dicey situation, and this boils down a little bit to personal preference. These scanners are a bit slower, so doing the cardiac scan immediately followed by CT angiogram, you may not be moving fast enough to catch the entire bolus for the CT angiogram, and may get poor CTA images. So a different approach that people have reported and try is splitting the bolus, doing initially injection of 80 cc's for the cardiac CT, and then doing another injection, moving the patient and doing another injection and doing your CT angiogram of the abdomen and pelvis. So you can do a gated of the entire chest and then CTA abdomen pelvis, or you could do just a gated focused in on the aorta itself and then a CTA of chest, abdomen, pelvis. It's kind of, again, nothing is set in stone there. It's really up to personal preference. Here's a slide showing the importance of saline flush. So when we first started using TAVR, we did not routinely use the saline flush, and then we quickly moved away from that and started using it because of what you see here. Again, if you remember, sometimes the subclavian arteries become important as potential access routes, and if you have streak from contrast in your subclavian vein, it makes your analysis of the subclavian artery quite difficult. So having the flush really helps with subclavian artery analysis. Here's some acquisition parameters that are available on the website. CT is us. I won't belabor this, but these are provided for the Siemens scanner here. And here's some other technical parameters. This is for the non-gated part of the CTA. In general, we use care dose in these cases, but we generally make sure we use dose that's sufficient to get good quality images. These are older patients, so radiation dose is not as high a concern as in other settings. What about your recons? We want to do thin slices, 0.75 millimeter thick slices with some overlap. You want to, for your cardiac, for your annulus measurements, you want to make sure your field of view is smaller and magnified up to the heart so you can get really good evaluation of the annulus itself. We create systolic, diastolic, and multi-phase recons. And then for the runoff, we always make sure to use iterative reconstruction. This really helps limit blooming artifact from calcium, and I'll just show an example here. This is iterative reconstruction on the left and filtered back projection on the right. The letters and numbers are specific to Siemens, but all the manufacturers certainly have these options available. I've just found that over time it's much easier to measure the actual vessel diameters on the iterative reconstruction compared to the filtered back projection, because you just have a lot sharper vessel wall. So measuring those vessel diameters, which is a requirement pre-TAVR, is just a lot easier in that setting. Okay, one last note before we take a quick break. Patients with poor renal function, this comes up a lot. So these are older patients with comorbidities, and so it's not uncommon to have people with reduced renal function. I would say that we're actually fairly liberal with giving contrast, and certainly anybody up to a creatinine of 2, we feel pretty comfortable using contrast. We really haven't had any issues. But if patients have really low GFR, less than 30, then you can do low dose protocols. There's a lot of this in the literature out there. Our own personal experience, we've taken 40 cc's of saline and mixed it with, or 40 cc's of contrast, mixed it with 20 cc's of saline, and then performed the cardiac CT angio. That works pretty well. Chasing that with the CTA of the chest, abdomen, pelvis, that's a little more problematic. But usually you get enough information that you can tell which would be a good access route. It's not going to be perfect, but it's usually good enough. The other possibility we've done as well is you can do a non-contrast MRI of the chest with gated images through the valve, and then a non-contrast CT abdomen pelvis that basically allows you to get an external look at the iliac diameters and how much calcium and disease there is. Clearly, you could be missing some stenosis from non-calcified plaque because you don't have contrast on board, but oftentimes that's good enough in these patients. So I think this is a good spot to take a little break, maybe stop and grab some coffee, and then we'll be back for part 2 and a little bit later.